So again, depending on your policy at your hospital, if we're shooting a pelvis like this, my place, we always left the underwear on. Some places, because now you have BR and CR, maybe that clothing will show up and they'll say, just get rid of it. Okay? But the key here again is to maintain modesty. Keep them covered. Okay? All right, so the entire pelvis and the proximal femurs are going to be included. Did we achieve proper rotation of the legs? Well, let's see. Do we see any lesser trochanters?
Mm-hmm.
We do not. Okay. Do we see greater trochanter?
Mm-hmm.
Yes. Do we see the neck?
Mm-hmm.
Yes. Okay. Now compare this with the left. Okay. We're not seeing the lesser, but look at the length of the neck. Does it look shorter than that of the right?
Yes.
So what does that mean with foot position? Okay, so if this is this, then the left must be somewhat like this, right? Because the more that you go externally, the more the neck becomes foreshortened, right? So this isn't as AP as this one, but is it acceptable? It's acceptable, it's fine. All right. AP bilateral frog legs. Now, this is for someone who comes in who has received bilateral or has injury or pain on both sides. Generally, we just shoot the one leg, one hip of interest. But this is done for somebody who has experiencing bilateral joint pain. So instead of taking one shot and another shot, I'll just take one shot to include both joints. Okay? This is very similar to that of the AP pelvis that we just shot here. Okay, except now what we're going to do is we're going to have them bend their leg approximately 90 degrees, okay, and then flop it off to the side about 40 to 45. So they're going to bend their legs about 90 degrees and then flop to the side about 40 to 45. Okay, now, when you look at this previous image over here, it says on an AP pelvis, we're going to center between the level of the as-is and the symphysis pubis. When we're doing bilateral, it's going to be approximately 3 inches below the level of the as-is. What happens here is we're going to cut the top of the iliac crest, okay? Because I want to see more of the femur. Because we already got it in the original shot. We already got the pelvis on this original shot. So now I'm going to center just a little bit lower to get more of the femur. So for the bilateral frog leg, you're going to center 3 inches below the level of the as-is. Okay? Oh, by the way, what are they doing with their breath? Are they breathing or are they holding their breath?
Breathing?
You want to hold it. Okay, because here's your belly, right? Diaphragm is up here, but also your belly is moving during respiration, so we want to suspend respiration, so there is no motion down here.
Is that for the femur as well, or just the pelvis?
Anything that includes the hip, you're going to have them hold their breath. So anything that includes the femoral head, you want them to hold their breath. All right, so there's your bilateral frog leg. Okay. You notice here that, again, we've cut off the top of the iliac crest. Not a big deal because we got it on the AP of the pelvis. Here we're going to center lower so we can see more of the femur. Okay, male or female? Female. Okay. All right, so pelvic girdle centered horizontally, no rotation to the pelvis, lesser trochanter equal in size, greater trochanters superimposed over the femoral neck with optimal exposure factors. Here's another key ingredient that I forgot to mention. When you guys have a patient that comes in from the ER, they're going to be on a bed, they're going to have a lot of blankets on them. Make sure that they are not laying on top of any type of cushion, or even if they're just off a little bit, you're not going to get a good pelvic shot. So you want to make sure that the as-is, the distance from the as-is to the bottom of the image receptor is equidistant on both sides with no rotation. So make sure there's nothing underneath them when taking these x-rays. Okay? All right. Now, I'm going to give you guys a little footnote over here. When you have somebody who has that has no rotation, this is what it's supposed to look like. If they have slight rotation of the pelvis, the side that they are rotated on, so let's just say I'm laying on my back, but I'm slightly rotated to the right. Okay? When I'm slightly rotated to the right, the ala of the right will be bigger than the ala of the left. This will look bigger, this will look smaller. Okay, if the patient was rotated to the right. You guys writing this down somewhere? Okay, so if I'm slightly rotated to the right, the ala will be greater than the one on the left. The other thing that you'll be looking for here is the obturator foramen will be much more open on the left than it is on the right. Again, the example I'm giving is slight rotation to the right. Okay? So the obturator foramen will be open on the left and will be somewhat closed on the right.
More open on the opposite side.
Yes.
Rotated right, open on
Correct. So based on what I just told you, there's one more open than the other.
Mm-hmm.
Yes.
Okay. So which way are they rotated?
Left. Or
They're rotated to the left. Okay? Because this is more open. If they're left, rotated on the left, this is going to be a lot bigger than this, and this is going to be a lot bigger than that. Is this acceptable?
yes.
It's all acceptable. I mean, you're not going to get the perfect x-ray, okay, unless you're me. All right, you guys see any rotation here?
Yes.
Pretty darn good, right? They're pretty equal, right? I can't see this because part of this has been cut off, but I'm going to look at that, and they look pretty equal, right? All right. Well, slightly, but I mean, it's still close to equal. Remember, you're not going to get the perfect. All right. AP axial outlet projection or Taylor method. So we're looking at the outlet. You can use an any size image receptor, but you're just going to collimate to an area of maybe 10 by 12, crosswise, 9 by 9. You don't need a lot of collimation. Okay, so patient on their back. Central is going to be directed 20 to 30 degrees cephalad for males, 30 to 45 for females. Why is there a difference in angulation?
Pubic arch is different.
Okay.
Different
Yeah,
size.
because of the pelvic construction or symmetry from male to female. So with females, there's going to be a lot more curves involved than it is with the males. So it's going to require more of an angulation with the females than the males. So 20 to 35 for males, 30 to 45 for females. Central is directed about 1 to 2 inches distal to the symphysis pubis. Again, are we feeling for the symphysis pubis?
Mm-mm.
Okay, just feel for the greater trochanter and go 1 to 2 inches below that. Okay, so elongated magnified pubic and ischial bones. So this is going to be elongated. No rotation of the pelvis. Again, we can look at both the foramina, and they look equal. Pubic and ischial bones centered to the collimation with optimal exposure factors. To evaluate the outlet. Give me just a second here. You know what I'm going to do? I'm going to scratch this. You don't need to know this. Yeah. Okay, so scratch out outlet. Okay. No need for you guys to know this. I'm just going to talk about common use. And you don't need to know this either, okay? So cross out inlet. Or do you want me to keep it on?
No.
Because I've heard a lot of, oh, no, no. Oh, that was good? Oh, that was good. Okay, I'm going to get rid of the acetabulum. Okay, so scratch off the Judith method.
Bye-bye, dude.
Yeah, so cross that out too. Bye. Okay. More? All right. So this is part of the hip study. Remember we had AP pelvis. Okay. Now we're going to focus on just the hip. So this is the AP hip on a 10 by 12 lengthwise. Okay. Now when I'm saying like 10 by 12, you know I'm not talking about the size of the image receptor. I'm talking about your collimated field, right? So you can use a small or a large image receptor, but collimate to an area of 10 by 12 lengthwise. Okay. Central ray will be directed to the mid-femoral neck. How are we going to find the femoral neck?
You got to go from the trochanter.
Okay, so 1 to 2 inches
in,
medial,
3 to 4 down.
3 to 4 inches down. Okay, that will take you to the femoral neck. All right? What are we going to do with the feet?
15.
Okay, the feet should also be rotated how much?
Okay.
Okay, is it 15 to 20 or 5 to 7?
15 to 10.
15 to 20?
No, it was 15 to 5.
10 to 15?
For AP?
Yeah, for the AP. What is it?
You said it was
5 to 7, isn't it? Yeah, 5 to 7.
We're not doing this?
No, it's 15 to 20 internal rotation for AP projection.
For what?
For a true AP projection.
For the hip.
Yeah.
Okay, 15 to 20 degrees medial rotation for the hip. Where did I get 5 to 7?
For the
For the knee?
Oh, for the knee. For the femur. Oh, for the femur. Okay, so 15 to 20 medial rotation. Okay, it doesn't say that here, but make sure you do that. 15 to 20 medial rotation. Okay, centered at the femoral neck. So when this is done, okay, what we have here is somebody who has a prosthesis. When you're shooting a hip x-ray, one of the questions you're going to ask them is, have you had any surgeries done to your hip? Okay, this is key in how you're going to position this, because instead of 10 by 12, you may have to use a larger image receptor, because if they have any hardware in there, you don't want to cut it off. So that's going to be one of the questions you'll ask in your dialogue. Have you ever had any hip surgeries? If so, when, da-da-da-da. Okay, so on and so forth, okay? So you're going to use a larger image receptor than 10 by 12 to include the entire prosthesis. So now, the proximal 1/3 of the femur will be included on the radiograph. The hip joint space and the acetabulum will be well visualized. Bless you. Now, when you have somebody with a hip prosthesis, you want to make sure that you can see the ball and the socket of the prosthesis. You don't want to see it fused as one glob like this. You want to be able to distinguish the head. Can you see the head? Okay. And the socket as two distinct parts. That will tell you whether or not you have proper penetration of the anatomy. The lesser trochanter lesser trochanter not visible or only slightly visible in a true AP, right? Total existing orthopedic appliance is demonstrated with optimal exposure factors.
Do they have a limitation for the positioning, this type of people? I mean,
Well, if it's immediately done after post surgery, they are going to be limited. Now, if they've had this for a while, they can absolutely do a frog leg for you. Yeah, once they've gone through their therapy and they're healed properly, then you can absolutely do the frog leg. But if it's a new, fresh surgery, you're not doing a frog leg. How are we going to get a lateral?
Horizontal beam.
Okay, horizontal
Or
beam,
or the-
inferior superior projection. Okay? So this is what you would do, okay, if this is a fresh, right out of the surgery, talking about hours within and a couple weeks, you don't want them doing a frog leg, this is what we're going to do. It's the inferior superior. All right? So inferior superior. This is going to be one of the situations where you are going to have to palpate for that pubic bone. Okay? So find your as is. Find the pubic bone. You're going to draw an imaginary line from there. Okay? The image receptor must be perpendicular to this imaginary line or parallel to the neck of the femur. The image receptor must be parallel with the neck of the femur or perpendicular to this line from the as is to the symphysis pubis. Okay. So the image receptor, when placed beside the patient, has to match the angle of the neck. Okay. Top of the image receptor will be placed about 1 inch to 2 inches above the iliac crest. Say 1 to 2 inches above the iliac crest. Top of the cassette. Okay. So the unaffected leg will be raised up and out of the way. Now, if they come from surgery, they'll be in a bed with traction bars. You see those traction bars on a bed? Okay. There's also a handle that you can grab on. What I've done in the past is I've used that handle as my trash can. So it's dangling from the traction bar, and I'll put their leg right through the handle, and their leg is resting on top of that trapeze. Okay? When doing the shot, okay, modesty is again important, but may not be completely covered because you need to see where your central ray is going, right? So you're going to get a show. Okay? Especially if they come from surgery. They're not wearing underwear, guys. Okay? So you want to try to maintain their modesty as much as possible.
We're still on
We're still on this.
We got back to it.
You got this purple.
All right.
The opposing leg's supposed to be elevated. Obviously, sure, her foot's on top of the tube.
I love that it's on top
Yes.
of the tube. That's
Right.
perfect.
Now, we try not to put it on top of the tube because unless it's locked in properly, the weight of the foot can cause the x-ray tube to move. Also, if you've already done x-rays, somewhere else, the tube might be hot. Okay, so we don't want them burning their feet either. Or, again, you can use a trash can, you can use the bar, you can use some sponges to get it out of the way. Okay, but the unaffected leg has to be put up. The other key ingredient here is, okay, they already have some cushion in the tush, right? So this is acceptable. But if you're shooting the x-ray on a gurney or on a bed, they're not going to be flat like this. They're going to be sunk in.
So you have to elevate them.
So now you got to get a whole bunch of blankets, shove it underneath them to raise the hip up. This is going to probably be one of your most challenging x-rays that you will ever do. Is this cross table hip. We call it cross table hip too.
We just shoved an extra IR under the lady.
Okay,
Like
so you shoved an extra IR underneath the lady
In a plastic, yeah.
in a plastic bag. Did you have to prop up the plate anymore to raise them up?
No.
Okay, so you did not. Okay, so yeah, so the text will show you some ways and techniques in how to prop up the bottom or the hip joint to accomplish this. Okay, but this is again one of the most challenging type of x-rays that you will ever come across. Okay, if anything, this is the one. All right, so when I was a tech, whenever a hip came from the OR in the recovery room,
You took a break.
I was gone.
So how come the femur head or femur neck is not close to IR? Why there is a space?
You can't do that because you're trying to match your image receptor and your X-ray tube. Otherwise, one of these, you're going to have distortion of your image. So you are.
The leg a little bit, the affected leg maybe closer to.
How are you going to do that?
It's dislocated.
Am I going to bring the leg out to match? And I can't put it flat like this, because if the image receptor was flat, shooting like this, now you're going to get distortion in the image. So the key here is you are going to have OID. Fine. Yeah, it's okay. I want to make sure that my image receptor is parallel. Okay, depending on what I'm talking about. I want to make sure my image receptor is perpendicular to my X-ray. Okay? X-ray beam must be perpendicular. That's why I was careful with my choice of words. Or the face of the image receptor must be parallel with the face of the X-ray tube. They have to be like this. Again, otherwise, if your tube is angled or your image receptor is angled, you're going to have image distortion. The other reason why we do it like this too is if you have any angulation of one of the two, okay, slightly not a big deal, but if you have great differences in the matching of the tube and the image receptor, you're going to have grid cutoff. Because we're using a grid, right? Because we're shooting greater than 10 centimeters, yes? Okay. All right. So here's the, for instance, when somebody's on the bed. Okay. You can see that a bolster was put underneath the bottom there to raise the hip up to make sure that it's included in your image. Okay. Top of the image receptor is going to be about 1 inch to 2 inches above the iliac crest. Okay. The face of the plate must be parallel with the neck of the femoral neck. What's my distance?
40.
About 40 inches, okay?
Do you want to back up a little because of the OID?
You could. You guys are doing digital. No, I'm just saying now, you guys are lucky that you have digital. So it's going to correct your image for you. Because the whole thing with the OID is you're going to get some magnification, which you lose some detail. But in this case, it's not a real huge OID, so there's not going to be a great loss in your detail. And again, it's digital, so the image corrects itself. So they have these now that you can buy, where you can prop your unaffected leg on this mechanism, or this contraption. And what Ms. Smith was saying was that if you're using the trash can, or if you're using the footstool, the closer that you bring it towards the patient's body, the more that the leg is pulled back. And we want it pulled back as much as possible because not everybody's going to have, light, lean muscle around the hips. Some of us may have, flabby hips, and now this is going to fall. The soft tissue is going to fall in the path of the X-ray beam, which can decrease the quality of your image, because now you're having to penetrate extra, meat and muscle. So you want to get their leg up as much as possible. Okay.
Like I says, perfect for bariatric patients.
Yeah, for the larger patients that can't hold their legs up, or we don't have anything to properly hold their legs up because their leg is so heavy. Yes. All right, so the entire femoral head, neck, and acetabulum is going to be very well visualized. What is this? What part is this?
The greater.
Greater.
Trochanter.
What area is this?
Lesser trochanter.
Lesser. What is this?
The head.
Head. What is this?
Neck.
Neck. What is this?
Acetabulum.
Acetabulum. And what is this?
The ischial tuberosity.
Ischial tuberosity. Looks like there's something going on over here.
A little chip or fracture.
So yeah, so he or she fell and hurt themselves. So there is no trauma to the hip per se, but there might be some trauma to their
butt bone.
Yeah, their butt bone, ischial tuberosity. All right. All right. This is frog leg for who? Trauma or non-trauma?
Non-trauma.
Non-trauma. All right. So the femur, again, bend the leg approximately 90 degrees. Drop it off between abducted 40 to 45. Image receptor is 10 by 12 crosswise. We're not going lengthwise anywhere because the leg is going off to the side. right? Because it's going off to the side, we want our image receptor to accommodate for the leg dropping off the side. So we're going to place the image receptor or collimation crosswise. Not lengthwise, but crosswise. Okay? Again, central ray is going to be perpendicular to the femoral, mid-femoral neck. How are we going to find that? As is, 1 to 2 inches down.